Fighting Blindness Canada's Viewpoint Education Series shares the latest in vision research, provides opportunities for you to ask your questions, and connect with other people who are living with a blinding eye disease. The session you're about to watch is a recording. To learn more about the research we fund and upcoming programs and events, please visit our website at fightingblindness.ca. Viewpoint is proudly presented by our Platinum partner Bayer and supported by our Gold partner Roche and Silver partners AbbVie, Astellas, Beacon Therapeutics, Johnson & Johnson, and Specsavers. Thank you for watching. We hope you enjoyed this session and share your thoughts with us in the comment section below. So we're going to jump right into the main event today. We are very excited to have Dr. Palanker here with us today. Retinal prosthesis, sometimes may have heard it referred to as the bionic eye, are one of the most popular topics for our eye health pages and our health information line. And today we're going to start to break down what these devices are, how they could restore a sense of sight, and share some information about ongoing clinical trials. Dr. Palanker will be in conversation with Dr. Larissa Moniz, who is our Director of Research and Mission Programs at Fighting Blindness Canada. That's going to go for about a half an hour, and then you'll have the opportunity to ask your questions. So we do encourage you at any time during the session, if you have questions, you can share them by clicking the Q&A button on Zoom and typing them in that box. Or you can always email us at education@fightingblindness.ca. That's education@fightingblindness.ca. And Shani's put that in the chat as well, if that's helpful. And yeah, so I'll be back in probably about half hour or so to help moderate your questions. But for now, I'm going to pass it over to Larissa and Dr. Palanker.
Thank you, Morgan. And welcome, Dr. Palanker. Yeah, feel free to put your video on now if you want to, and I'll give us a quick introduction. So Dr. Palanker, he is a professor of ophthalmology and by courtesy electrical engineering at Stanford University. And his research focuses on how electric fields interact with cells and tissues. And he uses this information to develop innovative optical and electronic technologies for use in eye care. And his lab work spans diagnosis to surgical to prosthetic applications, including the development of the PRIMA retinal prosthesis, which I know we will talk about today, which is currently in clinical trials. So a retinal prosthesis, it's a type of sort of implantable electronic device that can essentially simulate the sensation of vision in the eyes of people who might have severe retinal degeneration from diseases like retinitis pigmentosa or age-related macular degeneration. And so my first question to Dr. Palanker is, I find a relatively complicated topic. So I was wondering if you could explain to us what a retinal prosthesis is, as Morgan mentioned, sometimes called the bionic eye. So what is it? How does it work?
Thank you for the opportunity to discuss this topic, for inviting me to this webinar. So retinal prosthesis is a device that substitutes either lost photoreceptors, as in our case, implant called PRIMA, or the whole retina and stimulate the other cells to transmit visual information to the brain. So in our case, it's a subretinal prosthesis, so it's inserted under the retina, and it is designed to replace just the lost photoreceptors in a disease called geographic atrophy or atrophic stage of age-related macular degeneration, where photoreceptors in the center of the visual field are missing, but in retinal neurons, two layers of processing neurons, bipolar cells and then ganglion cells, are still present. So our device is inserted subretinal instead of the missing photoreceptors. It converts light into electrical current in each pixel. And this electrical current stimulates the nearby bipolar cells, so it's a second-order neurons. And they transmit the response to ganglion cells and to the brain. So this way we restore the flow of visual information. So in our case, the prosthesis is designed to replace just one layer of cells, the cells that are missing photoreceptors in this disease. and we rely on the rest of the retinal network being still in place. For that reason, it will not work, for example, for glaucoma, where ganglion cells are missing. So there is nothing to stimulate, and you cannot transmit information to the brain anymore. And the implant should be placed in other places, like in optic nerve, or in a visual cortex. So that's a subretinal implant. In our case, it's just photovoltaic array, and I can describe later exactly how it works. The epiretinal implants, like Argus 2, for example, is the best known example by a company called Second Sight. It is designed to place above the retina and stimulate the output layer of neurons in the retina, ganglion cells, directly. So basically, it ignores all the retinal signal processing up to the ganglion cells, and therefore it needs to encode information differently in a way that ganglion cells are encoding visual information, which is more challenging because there are 24 types of ganglion cells. Each of them encode different information differently. It always transmitted in parallel to the brain, and then it merges into a person. So this implant doesn't rely as much as we do on preservation of the inner retinal network because it stimulates the output cascade, but it requires much more complex encoding of information from the camera, from the image to the code that you deliver to ganglion cells. So the two main types, subretinal and epiretinal types of retinal prosthesis. There are also cortical prostheses that people work on in cases where retina is damaged, like in glaucoma or trauma, and then there is no way to transmit information from the retina, and visual information is injected, for example, directly into visual cortex. There are several types of cortical prostheses. And one of them, maybe the best kind of known in the news now, is a Neuralink that promises to do this blind sight implant. That's exactly the cortical approach. It has a lot of other challenges, and if you want, I can talk more about that, but it's a kind of separate topic. So if you like, I can describe in more details how the prosthesis works, what it does.
Yeah, that would be great. Actually, it was sort of really timely because someone just sent me an article today about Neuralink, but using it for spinal injury because they've done some implantations in Canada for the first time, actually. So if anybody sees that in the news, it's using this implant, but for a very different purpose, not yet for vision restoration. Yeah, so I think that was a really great explanation of using this electrical chip essentially to create a light source at different levels of the retina. And depending on which cells are damaged, you may have to put the chip in different places essentially. Yeah, could you explain a little bit more about the actual hardware? So if both for your system as well as others.
Yeah, so let's start with our system because I think it's simplest. We just use a photovoltaic array. It's basically like each pixel is like a little solar panel on a roof, right? That converts light into electrical current. So our pixels convert light into electrical current. It's just photodiode, basically. And because natural normal photoreceptors have high amplification of light into electrical current up to a factor of 1,000,000, and photodiodes don't have it, we have to use more intense light. So what we do, the hardware includes augmented reality glasses that have a camera and a projector. It's like Google Glass in a sense, if you know what that. There are several augmented reality glasses on the market now. So the camera captures an image, it is processed and then projected into the eye from a display on the glasses onto the retina, onto the chip, using invisible wavelengths, near-infrared wavelengths, about 880 nanometers. And the reason we use invisible light is because it is intensified, so photodiodes will generate enough current to stimulate neurons, and we don't want to overwhelm with visible light, remaining photoreceptors. Because in our case, age-related macular degeneration patients have normal retina outside the scotoma, and you don't want to use very bright light. So we use invisible wavelengths for that reason. Now, the image projected with this light, it's also pulsed because we stimulate neurons in pulses. Converted in each pixel, light is converted into electrical current that flows between two electrodes. In each pixel, there is active and return electrode, and the current flows like little fountain in front of the pixel. And neurons that happen to be just in front of the pixel feel that electric field. They polarize an electric field. And polarization of a neuron results in a voltage change across the membrane, and ion channels that are sensitive to voltage respond by opening or closing. In our case, it's a calcium voltage-sensitive ion channels that open in response to depolarization and allow calcium in, and this signal is then transmitted to ganglion cells. Like naturally it is in retinal signal processing, goes from bipolar to ganglion cells through calcium influx. So we basically hack into the system by polarizing bipolar cells in electric field, and then everything else after that is natural. They respond by release of neurotransmitter glutamate onto third-order neurons, amacrine and ganglion cells, and then from ganglion cells generate action potentials. They're spiking neurons, and these action potentials propagate through optic nerve to the brain. So all that is natural, and because we rely on this inner retinal network doing its job of signal processing, the signals that are generated this way, we measure them ex vivo and also in vivo in animals, they retain many features of natural retinal signal encoding. And that, I think, is a key ingredient for brain to see it as an image, not just light, but really form vision. So they see letters, patterns, and so on. And that, I think, is important, that we utilize a preserved retinal network to encode signal properly.
I think that, go ahead.
Briefly how the hardware looks like. So you have augmented reality glasses to do the job outside the eye, capture an image and transmit it from projector to the eye. And the implant is very simple. It's just a thin array, 30 micron thin. In our case, 2 millimeters wide. It's a thin film, basically. 30 micron is half of the thickness of photoreceptor. Natural photoreceptors are about 70, so it's even thinner than that. And it is inserted just under the retina without any suturing or any pins. It's held by the retinal attachment. Because it's so light, it's actually held in place just by the retina being reattached. So that's the hardware of our approach.
And in terms of sort of the limitations of the images turning into an image that the brain can see, is it the camera sending the right light signals to the chip, or is it the chip being able to send the right signals to the brain, or is it both? They're both still being worked on.
So the camera captures images, in front of you, basically, and all we do, we can enhance contrast, we can amplify the signal just to make it, bright enough so there is enough current to stimulate bipolar cells, but there is nothing very sophisticated in image processing we do at the moment. We basically just try to do what photoreceptors do, convert light into changes in cell potential. And so the signal is converted into pulses of few milliseconds in duration at repetition rate of flicker fusion 30 Hz. So it looks like steady percept, even though it's pulsed. It's pretty much like video frequency, like 30 Hz is normal video stream frequency. And so it's not very sophisticated image processing. It is just contrast enhancement and intensity is increased for sufficient stimulation, but not much more than that. In stimulation of ganglion cells, the image processing becomes much more sophisticated because the code of ganglion cells is spiking, and you need to encode it for different cell types different way. There are on cells and off cells, and cells with different characteristics of resolution, contrast sensitivity, and color, and so on. That is much more challenging, but we don't do that. We have much simpler encoding. By the way, what patients actually see is not color vision, it's a grayscale prosthetic vision. They describe it as a sun color, so it's kind of white yellowish. And it is monochromatic because we don't have selective stimulation of different color channels. That is much more challenging. It requires not only single cell resolution, it's actually antagonistic input of different colors into the same bipolar cell, like red and green with opposite signs, or blue and yellow. So that is much more challenging in terms of design of the implant to high resolution. And currently it's a grayscale prosthetic vision that we get.
And actually, maybe you can talk a little bit more about that. So when you talk to some of the patients who have received either the Pixium or maybe other types of retinal prosthesis, what is their vision like? Because you're saying that they can actually see letters and objects. For
our case, we have about 45 patients now, most of them in Europe, 43, and they describe it as patterns of light that they see, letters or any other patterns we can project, gratings and so on, that they see as a pattern vision. And it is currently for tests of reading, it's basically black and white imaging. It's they look at vision chart, it's DRS chart, and they read letters, and and we can check how fine is their vision, basically which lines they can read. And on average the improvement now is by 5 lines compared to their baseline. Our system, by the way, includes also electronic zoom. So by looking at the letters, they can add zoom and resolve smaller letters than the pixels would allow. Pixels themselves are 100 micrometers currently, and that corresponds to acuity of 20/400. So it's large letters. But with electronic zoom, they can read down to 20/63. So it's a big improvement, about 5 lines on average. The clinical trial that was conducted last year in Europe, the criteria of success was basically at least 2 lines of improvement on a TDRS chart, and we got 81% passing that threshold, and 79% got 3 lines of improvement. And on average, as I said, it was 5 lines of improvement.
Wow.
Yeah,
Can you explain a bit more about the
implant, but not every other implant had that. Retinal implant Argus has very different perception. They generated sensation of flickering lights, but not really a form vision to the best of my understanding. They saw that light and they could scan by moving the head and kind of figure out what is the object that they're looking at. For example, if it's a line on the floor, by scanning they can find that line and walk along this line, or find a doorway by scanning, and finding where it is. But to read a letter, for example, with this sort of point by point kind of scanning, it takes a very long time. In our case, it's instantaneous. They can read a page of a book, basically, and it's even word by word, not even letter by letter reading. And I think the difference why it is so successful in our case, why it is form vision, not just light sensation, basically, it's because we retain the retinal signal processing to a large extent. Because we go through retinal network, we allow retina to do its job of properly encoding the signals, instead of going all the way to the output of the retinal ganglion cells and stimulating them. And that's much more challenging to make it understandable for the brain.
When, for say Pixium, when people get the retinal prosthesis, is there a period of training that they have to do to be able to interpret?
Yeah, it's a very good question. There is a period of training, and now we have so many patients, so we see that there is a wide distribution of their abilities. Some of them, we call them super patients, they see it right away, very clear, bright, and lines are straight and everything is good. Some see initially images like noisier and lines maybe not straight, but over time they go through the training sessions, maybe weekly or so. The brain probably learns a new language, new code, and at some point that it transitions into clear image. The background noise disappears and the lines straighten up. So I think there is some sort of neuroplasticity involved, that we see improvement in measurements in a clinical trial, we have measurements of acuity at 6 months and 12 months, and we see improvement from 6 to 12 months. And that, based on this description of patient, that it is kind of sudden transition, that there is a period of time that brain learns the issues and maybe learns how to interpret, and suddenly it becomes clear and lines straighten up. And the time point where this transition happens varies between patients. As I said, some have it great from the beginning, some take time to get it right. So that's probably some sort of neuroplasticity.
And I don't know if you know this information, but in the patient's day-to-day lives, have they told you about things that they can now do that they couldn't do before, or that?
Yeah, so patients have it at home, and they now can read, and they use it in all sorts of home tasks like cooking and playing cards and so on, that they couldn't do before. And so it does, affect their quality of life. My hope, though, that the next generation implant with much smaller pixels, now we have pixels 5 times smaller, instead of 100 microns, it's 20 microns, working well in rats. And we are working on translating this chip into human version now with the Science Corporations that acquired Pixium a year ago. And I hope that if it works as well as it's working in rats now, in humans, it will be much, high quality vision. It will be about 10,000 pixels or maybe 20,000 pixels in the implant, and they will be able to read much smaller fonts, and we zoom down to 20/20 normal vision. Without zoom, it will be about 20/80. I don't think they need 20/20. I probably don't have 20/20 myself. But 20/40 is perfectly fine. It is sufficient for driving and so on. So my hope is that next generation implant will really make it very practical and widely used.
So I've got 2 questions. The first was sort of a technical one about the zoom. Just, it was a really fascinating thing you said about the zooming. So are they manually looking at something and then zooming in, or it automatically zooms for them?
No, it doesn't zoom automatically. They have a knob on the controller that they can select, and they in a clinical trial we allowed them to do it at their wheel. Basically, everybody can select the level of zoom they're comfortable with, and that's what they do. And they very much like it. By easily turning on, you suddenly see much smaller fonts, so they like it. It is limited basically by stability. When you zoom in, your head movements become much more noticeable, right? So it depends how stable it is. Probably in the future, we'll use some sort of electronic stabilizer of an image, so this issue will go away. And as I said, I hope that much smaller pixels will work well, and they won't need that much zoom either.
And then my second question was around sort of the eye conditions. So I know right now this is being tested for geographic atrophy.
Right.
Do you think this specific or the next generation would also be useful for different types of inherited retinal diseases as well, or is it very specific for AMD?
Yeah, so we do plan to try it next in Stargardt disease, which is similar to AMD in the sense that there is the loss of central vision is a characteristic of the disease with the peripheral being preserved. It is not as prevalent though, so it is a much smaller market, but we do plan to try it with Stargardt disease, and if it's successful, then we'll try other RP conditions. My concern that we may face, retinas in RP that are much more rewired than in AMD, because in AMD, only a few millimeters of the central part of the retina lose photoreceptors, and everything else is normal, and so retina is maintained in a relatively normal state. Even the central retina gets some signals laterally propagating from the areas where photoreceptors are preserved, which keeps the retina normally layered, and I think it's important for preserving the signal processing. In RP patients, they lose all photoreceptors eventually, and retina undergoes much more extensive rewiring. And I am not sure that this rewiring will allow us to preserve the retinal signal processing as well as it is preserved now. But we'll see it in a clinical trial. And I hope that in the Stargardt disease, it probably is still well preserved. but in RP, we'll see.
And in terms of, again, about the potential candidates for this type of treatment, would it be for individuals who have lost a lot of vision already, or would you imagine a time where, for instance, with an inherited retinal disease, even though they still had some vision, you put in the prosthesis because then the rewiring perhaps hasn't happened yet?
Right. So you can only put this prosthesis where photoreceptors already are lost, because separating photoreceptors by subretinal implant from choroid and retinal pigment epithelium will kill photoreceptors. They rely on diffusion of nutrients from the choroid. So we can place it where photoreceptors are lost, and but we can put it early in the disease where they're not lost, as many or as broadly in AMD. And because the implant is modular, we can keep adding them later when the scotoma, for example, is growing. So it may help preserve the inner retinal structure and prevent, very extensive rewiring. You are right, but this remains to be seen.
Okay, that makes a lot of sense. We touched a little bit on it earlier in the conversation, but I was wondering if you could talk a little bit, if you know about results from other types of retinal prosthesis. You talked a little bit about the Argus, which I know is no longer being
supported, Argus was
right?
taken off the market because results were disappointing, and so they switched to cortical stimulation now. There is a Orion implant, which is basically a repackaging hardware of a retinal implant into the shape suitable for the cortex, larger electrodes and so on. The results from that trial were published, and patients could not see patterns. That's, I think, is the biggest challenge with cortical stimulation, because it's so far from the retina. Information is processed in a very distributed way in many parts of the brain parallel. And cells are very specialized, and the way the image is presented is by very abstract representation of features of the visual scene, not point by point, just bitmap. And reproducing that is very difficult. So what patients report, they see phosphines elicited by different electrodes, but if you stimulate them simultaneously, they don't see a pattern. Like you stimulate one electrode to get one phosphine, another electrode to get another phosphine, stimulate them together, and you get a third phosphine somewhere else, not two of these. And that's a very serious challenge for all the cortical implants now. There are two groups in the US that already have patients, one from Chicago, a group of Phil Troik, and another from Alicante in Spain, or Elche, actually, close to Alicante, by Eduardo Fernandez. And they both report those issues, that the pattern stimulation is not perceived as a pattern. And the trial with Orion implant by Second Sight was done in US, and they also reported the same problem. The way they overcame it for that trial is that they just sequentially activated one electrode at a time and created like a sequence of moving dot, basically. And this way you can see a pattern. But it's not scalable to, thousands of pixels. It's okay for a few pixels, but not scalable because it's a slow scanning. So this, I think, is one of the biggest challenges with cortical implant. Can you really produce a pattern vision? And so that's why Neuralink promising this blind sight, I am quite skeptical that it will work well, because this challenge is still unresolved. But, never say never, we'll see.
And are there any other companies that are developing retinal prosthesis?
Yeah, so with retinal prosthesis, there was another company that also closed called Retinal Implant AG in Tübingen, Germany. Their implant called Alpha, IMS and AMS, was subretinal. It was a camera, basically, that avoided the need for external camera that we have. And they produced also kind of flickering light perception. Few patients could resolve some letters, but most of them couldn't. And the biggest problem was that these implants, because it was a camera with a power supply and complex electronics, they all were failing over time, over several months. And so they had to be explanted, and the company couldn't fix that, and eventually they closed in 2019. So currently there is nothing that really works except for us in the retinal domain, retinal implant domain. People are still trying. There are new ideas and new groups forming, but there is nothing that really is working clinically. But several groups are in the clinical trials with the cortical implants, as I mentioned.
And I guess sort of two quick questions before I open it up for audience questions. So in terms of there being a sort of a piece of hardware in the eye or in the cortex, do you see any challenges with that? I know when the Argus, when they stopped supporting it, all of a sudden people had sort of devices there. And so
no, certainly any device, any implant that you place in a body, the company is responsible for whatever is happening there. So if it goes out of business because they run out of money, it's an issue. I don't know how to address it, by the way, because it's not clear who is responsible when you're out of money. But so I think Argus second sight provided some support, and patients who wanted to explant could explant it. Fortunately, in our case, there is a continuation. So Pixium was acquired by Science Corporation, and all the patients are now enrolled in continuous studies. Actually, the next phase for our study is face recognition. It's not just reading. It's a second line, kind of, I would say, in a wish list. The first is usually reading ability, patient mentioned. The second is face recognition. So we are working on that. It's a mostly image processing software optimization. And then we'll be working on a new implant of high resolution version. But your question about hardware, left if the company goes out of business, it is a serious issue. It's not only related to prosthetics. Any implant, by a startup will have that issue that if they go out of business, what happens? And it better be just safe. Our implants are very safe in the sense that they are passive. There is no active electronics there. It's activated by light. And they will outlive our patients. They don't erode. So I think in the future, archaeologists will be wondering what is the chip in the eye. They will survive longer than patients.
Okay. And the last question was, like, in the sort of landscape of restorative therapies, where do you see retinal prostheses fitting compared to, for example, stem cell therapies or optogenetics?
Well, optogenetics so far didn't produce anything, impressive. The one study that was published by GenSight demonstrated light sensitivity, but not form vision. Again, very similar to second sight. They could see light, and by scanning slowly, they could figure out what is in front of them, like a cup or two cups, for example, on a table, they could identify. So that's exactly this issue of proper encoding is a key. And they stimulated ganglion cells optogenetically, and the code was not anywhere close to natural, and brain just couldn't see more than just light. It wasn't a shape. So I know other optogenetic companies are trying, and there are different claims, but I didn't see anything convincing yet. But it is ongoing, so people will try stimulating bipolar cells and maybe even remaining nuclei of photoreceptors. There is a stage where nuclei are still there, while outer segments are gone. So yeah, the efforts along these lines continue, and it's hard to predict. It's all competition of approaches. Stem cells also are being tried in several ways. First, to replace RPE, and that maybe is the easiest, and then replace photoreceptors, but that's much more challenging because you need to wire them to bipolar cells, and that was a bottleneck. It's all going in parallel. Who will win? You never know. Maybe even just prevention of degeneration will be the most productive approach if you can develop something along these lines. But like, for example, with cochlear implant, it was developed, 3 decades ago, right? Maybe even more. It was approved in the 90s. And it is still the best approach for restoring hearing, right? Despite all the efforts doing it otherwise, the cochlear implant is the one that is really doing its job. It's implanted now in more than 1 million patients, even in small kids that are congenitally deaf. And So we'll see what will happen with retinal prosthesis. It may be the same, that it will do its job, and while other approaches are being developed.
Well, thank you. I've really enjoyed this conversation. I've learned a ton. I'm going to call on my colleague Morgan, who's going to let the audience ask some questions. I can see a lot of them have come in.
Oh yeah, we have lots and lots of questions. Thank you both. That was really interesting and insightful. So we have so many questions, and I'm just noticing some themes here. And I know, Dr. Palanker, you did touch on this, but if we could just maybe talk a little bit about sort of the potential for use in other diseases. So a lot of people are asking about retinitis pigmentosa, what the applications could be for someone who has that condition. There's someone who's asked about glaucoma. So can you talk a little bit about the possibilities beyond?
Yeah, so we will try, now that we have a success in AMD, we will try NRP. I think it is more challenging because retinal condition NRP is much worse due to rewiring, due to loss of photoreceptors globally, but it may work. It is also lower threshold of success because these patients have much lower vision than AMD. You don't have to restore even maybe reading ability just for orientation if you provide enough information to get rid of white cane and guide dog. It already will be an achievement. So we'll try and see if that works. For glaucoma, though, it is much more challenging because if ganglion cells are damaged, then there is nothing to no cells to deliver this information to the brain in the retina. So either apretinal or subretinal approach will just face this issue of absence of ganglion cells, and that is a major issue. So with glaucoma, I think there is no other approach than just going further down the vision stream and LGN or visual cortex.
The other one I'm seeing quite a few questions about is retinal detachment, or also like the level of vision. So if you have absolutely no vision in one eye, is that still a candidate for?
Well, if you have a very good vision in one eye, I wouldn't recommend implanting in a fellow eye because the brain integrates, and usually one eye vision is okay, except for maybe stereoptic effect, but it's not critical. And with low resolution implant, you won't get stereopsis anyway. So I wouldn't do that for just one eye if the other eye has very good vision.
Thank you. A couple of questions here about depth perception. So is depth perception restored with the implant?
Currently, we do only monocular implantation, right? So in a worse eye out of 2. And I don't think there is that issue of, proper depth perception is addressed. I think it is still, for AMD patients, I don't think it's a critical issue because the level of vision they have is sufficient for orienting themselves in space and judging the distance, even though the acuity is insufficient for reading. But all those issues of proper judgment of the depths by parallax and that requires very high acuity is currently not in the cards with 100 micrometer pixels. With smaller pixels, it may be doable. And again, it's also dependent on what is the condition of the fellow eye. If the fellow eye has also very low resolution, which is usually the case, then you need to implant in both eyes. And currently, we don't do it. We do just the worse eye.
And what is the reason for only doing it in one side in the trial? Is it so you can kind of?
Well, it's a clinical trial. First of all, we didn't know if it will work at all. So you don't want to jeopardize both sides. And so we started with the worse side. But yeah, if it works, great, and they will want both sides to be brought to that level, then maybe we can do it for both sides, yeah.
Thank you. And you mentioned the pixel resolution there. Can you talk a little bit about that? Both like what the pixel resolution is now, where you hope to get it, and is there a way to describe sort of what that what that
Yeah, so
actually looks
let's
like.
start with what normal vision
Mhm.
is in terms of resolution. So normal, what is considered 20/20 vision, corresponds to equivalent pixel on retina of 5 micrometers. Our current pixels are much larger. It's 20 times larger. It's 100 micrometers in humans. In rats, we already have a version 5 times better, 20 micrometers working. And that, so 20 corresponds to 5 microns. 100 micrometer pixels will correspond to 2400. So you can basically read large fonts of a title of a book or something like that. And with 20 micrometer pixels that we have working in rats now, it's equivalent of 2080. So it's about twice lower than what you need for driver license in US. You need 2040 acuity. But we use electronic zoom and they can see much smaller fonts. But it comes on account of reduced visual field, like any zoom, right? When you look at a telescope, you can resolve objects far away, but your field is narrow. So that's a trade-off.
And in terms, you've mentioned before this idea of potentially in the future adding image like stabilization specifically. Yeah. So how would that work? Would that be part of the implant or is that part of the process?
No, it will be a part of the camera software, basically. The cameras usually have a sensor of vibrations and it can stabilize electronically automatically if you allow it in. It will be a software coming from the glasses.
Great, thank you. And the vision that's restored, I think you mentioned this, but just to go back, is it in it's black and white or it's across like a grayscale?
So yeah, they see many levels of gray. If you turn on, the power, they can tell that it's become brighter, brighter, and brighter and brighter. But currently in reading, we utilize just the brightest settings of black and white, basically imaging. For face recognition, though, it's not good enough because you want many levels of gray to resolve faces, and that's a new kind of software modality that we will add in the next clinical trial.
And you mentioned a bit about the field of view. So someone's asking how large is the actual implant themselves, and then what's the field of view that's available?
Yeah, so currently the version that is in this clinical trial in 45 patients, it's 2 by 2 millimeters rectangular. So diagonal is about 2.7 millimeters rounded edges, and it corresponds to about 7 degrees of the visual field. The image projected from glasses into the eye that allows you scanning, it's the size of a screen eventually, actually, that you're kind of looking at, is about 18 degrees. So it's like Google Glass. And within that size, you scan and you can basically look at the text and so on. Beyond that size, you have to turn your head and allow camera to capture other parts of the visual scene, right? In the future, we plan to use larger implants. Typically, scotomas in our patients are at least 4 millimeter in size, and some of them are larger. And so we plan to put implants of 3 millimeter, maybe even 4 millimeter in size. I think the company will just offer multiple sizes, and physicians will choose which size to use in different patients, or maybe even fill scotoma with multiple modules. We did this in animals. We did about 7 modules in one eye just to show feasibility of that approach as well.
Thank you. And then some questions about the implant and the surgery as well. So once someone would have the implant inserted, is there things that have to happen to them after? For example, do they have to have injections after the surgery? Is this implant permanent? Can it be removed?
Yeah, so the implant is just inserted under the retina and left there. After surgery, there are 2 ways to reattach the retina after subretinal procedure. One is with silicone oil, and then it needs to be removed a couple months later or a month later. Or the other is a gas bubble that will push retina, reattach it, and then it will disappear on its own. So you don't need to remove anything. One way or the other, it is the patients are allowed to heal for a month or 2 until the oil is removed or air bubble disappears, and after that there is no interventions required, no injections, nothing. It's just sitting there under the retina, and it's stable. It keeps working. Now we have follow-up of more than 5 years in our first patients, and the chip is still working, and patients still use it.
Have there been any trials? Someone had asked specifically for RP, but in general, have there been any clinical trials, do you know, in Canada, or are they mostly focused in the US?
No, it is mostly in Europe. Actually, first 5 patients were done in Paris, in France. Then 38 patients in a second trial called Primavera were all over Europe, 5 countries, 17 hospitals, including Italy, Germany, Netherlands, France, and UK. And 2 patients were in US because we were given a permission by FDA to have 5 patients of the feasibility trial. But it started during COVID time or just before COVID time. And because of COVID, everything kind of stopped. And in Europe, they got so many more patients that basically this 2 became kind of irrelevant. And so these American patients are not a part of our statistics now of what we are going to publish in a European trial. But the next trial, actually, I think maybe in Australia, but not in Canada, to the best of my knowledge. But it depends usually on people who kind of, step forward and offer, participation. If somebody wants to do it, then it may be in Canada.
Yeah, so we have a few questions, and I may ask Larissa to pop back on to sort of talk a little bit about this as well, just from a Canadian perspective. So a couple of people are saying, like, when this, a little bit about sort of the approval process for it to be available to patients outside of the clinical trial. So what steps still need to happen, and sort of how long or how far down the road that is. And maybe Dr. Palanker, if you could talk about that from like the research perspective, and then maybe Larissa can chime in about how that process works in Canada. Yeah,
so currently the results of this pivotal clinical trial that took place in 23-24 in Europe are submitted for European approval. It's a CE mark. It is equivalent of US FDA, and we hope that we'll get approval for becoming available in the market as a medical product in Europe. In US, it will require FDA approval, and they want some American experience, some American patients, American physicians. I don't know how many yet. We'll see. We are in touch with FDA. And I don't know what are the rules in other countries. If FDA, for example, is sufficient for Canadian, healthcare system, or they need their own approval, and I have no clue how difficult it is.
Yeah, and then in terms of sort of in Canada, it's quite a long process. We normally fall somewhere after Europe and the States, usually right after the EMA and the States, and trying to get approval. And in terms of it being covered or not covered, it really depends on what the efficacy of the product is.
Oh, yeah, of course. The same in US. FDA approval is, safety, but efficacy as well. But reimbursement is a completely different story. So yeah, it needs to be shown to be sufficiently improving, quality of life, and then it's all separate set of questions.
Yeah, the Argus 2 was covered specifically in Ontario for patients with advanced retinitis pigmentosa. So that's like a very small case, but it gives you some suggestion that the regulators are open to covering some of these devices.
Right. Yeah.
Thank you. Thanks to both. So another question, a couple questions we have here is about, and I think you've touched on this, but if you could say a bit more. So if, for example, a patient got the implant now and there were then updates to it in the future, maybe around the pixel size or the technology, does that mean they'd have to have a different implant, or would that be?
Yeah, that's actually a great question, because we demonstrated recently and published a paper that you can remove an implant of, say, low resolution, put an implant of high resolution in exactly same place, and it provides higher resolution vision. We did this in rats, not in humans, but it shows feasibility that you can upgrade not only glasses and software and camera, which is outside the body, but the implant itself as well. It's certainly a surgery, but it's not very complex surgery. You just kind of pull out this thin film of implant and put another one in exactly same pocket. So it is feasible, and it probably is important for FDA in terms of approval that if something goes wrong, it's relatively easy to remove and even replace with a new one.
Another person had a question. Does the implant affect intraocular pressure?
I am unaware of any effects on IOP. Maybe surgery itself affects it because retinal surgery affects everything, and maybe you have to regulate IOP right after surgery because of silicone oil and everything else, but not the implant itself. Implant is a small piece, of thin hardware sitting under the retina.
Another question about are there restrictions for potential candidates for the device due to other health concerns or things like smokers? They mentioned drinking coffee. I really hope that's not a deterrent. So are there anything that would prevent someone from having?
I think the exclusion criteria were such that there should be no other ocular diseases than, for example, AMD in our case. So it's just ocular diseases that they didn't want to include, very complex cases in a clinical trial with other diseases involved. But the implant itself doesn't affect anything in terms of metabolism, so you can probably keep drinking coffee and everything else. Alcohol, I don't see any limitations on that. Yeah.
Another question was, and you mentioned Neuralink kind of at the beginning, but the question was, is this something that could be integrated with something like Neuralink or similar receivers? And are you looking sort of to develop sort of this interface in partnership with other companies, or is it primarily through?
No, I think our implant is unique that the interface is optical, so you have to have the augmented reality glasses designed for that. It is one directional. We only transmit information to the implant and it stimulates the retina. We don't read out. By the way, maybe it's a good point to mention that there are two types of brain-machine interfaces. One is readout. You read out state of the brain, activity of the brain, and find correlation between that activity and intended word, for example, for restoration of speech, or intended motion for restoration of motion. And that is relatively easy because all you need is to get good signals and find some correlations. The implant we are working on is write-in. So you write information into the brain, into the retina in our case, but that's extension of the brain. And that is much taller order, much more difficult to write information in a way that brain will understand it. So it's much more challenging. In our case, the system is one directional. We only deliver information to the chip and stimulate the retina. Some implants have bidirectional capabilities. They can stimulate and read out. And I think Neuralink, so far what Neuralink did was just reading out for patients with paralysis, but they do intend to stimulate with this blind side implant, and we'll see what the results will be. It's hard to predict. As I said, cortical stimulation is very challenging to create form vision. But readout from the cortex was shown to be certainly informative enough to decode intended motion or decode speech. So several companies work on restoration of speech, and that's very exciting.
There was another question too, just about sort of research and the landscape that you're working with within the state. So are the current state of affairs in the US right now with the FDA and healthcare, is that impacting your research at all?
Sorry, what is impacting?
Like the current US political landscape.
Changes in FDA in overhead, I guess, right? You're asking about overhead. Yeah. So far, it didn't change, didn't affect anything because I think it is frozen in the courts. Currently, our grants remain at the same, overhead level as we had. Going forward, I don't know. It's a two-sided kind of sword in a sense, because reducing overhead will allow more money to go for research, right? Less go for administration, which is a plus, obviously, for researchers, but it also puts more burden on universities to cover the administrative expenses, right, and facilities. So we'll see how it will play out. But so far, at the moment, the grants are at the level they were, and overhead at the level they were. So there are no changes yet. I just received some supplemental funding, for example, just recently, and everything was exactly according to old rules. So I don't see any changes yet, but it may come, and we'll see which way it will change the system. It may benefit, as I said, or it may hurt.
Well, I'm glad to hear that things are going well. So I think we have time just for like one last question. So there's been a couple questions about how individuals can apply to take part in a clinical trial. So I will just say that, again, there are some trials happening in Canada, not necessarily for this particular technology, but there are other things happening. So we do have a list on our website of sort of innovative clinical trials for both AMD and for inherited retinal diseases. So maybe I'll ask Shani to post those links in the chat so people can take a look. Of course, we always recommend that you talk to your doctor about what is going to be best for you, but we can also help you find resources through our health information line, so you can always reach out to us there. And then to you, Dr. Palanker, like, do you have any advice for anyone who's interested in learning more about clinical trials?
So for a clinical trial with our implant, PRIMA, they should inquire through the website of Science Corporation. They have I think a tab for clinical issues, and the director of clinical trials, Ralph Hornig, is in charge, and I think his email is probably there. So yeah, so it all should go to Science Corporation website. It's a company in Alameda, next to San Francisco. So for us, it's much more convenient now. It's a driving distance. And they certainly intend to conduct clinical trials going forward for other indications and for other, image processing capabilities and so on.
Thank you. Well, that was great. So I'm just trying to respond to a few more questions here. We didn't get to every question, but we tried to get to as many as we can. A huge thank you to Dr. Palanker for joining us today. It's been so interesting and insightful, and for answering all of those questions. Really appreciate your time. Thank you so much.